Okay, now let us start with other DNA viruses causing cutaneous infections. Parvovirus infection. Morphology. Parvovirus are the simplest animal viruses infecting humans, responsible for a common childhood exanthema called as erythema infectiosum fifth disease. They are the smallest viruses, 18 to 26 nm in size, non-enveloped with icosahedral symmetry. They are the only DNA virus to possess single-stranded DNA. Parvovirus P19 is the most common parvovirus pathogenic to man. They depend upon the host cell enzyme for replication. Pathogenesis. Parvovirus B19 exclusively infects humans. Transmission by the respiratory route most common, followed by blood transfusion and transplacental route. Infects precursors of RBCs. It has a special tropism for erythroid progenitor cells present in the adult bone marrow and fetal liver, as it binds to the blood group P antigen as receptors which are present on the RBC surface. This results in destruction of RBCs and inhibition of erythropoiesis. Clinical manifestations. Erythema infectiosum or the fifth disease. In children, it produces rashes on the face with characteristic slapped cheek appearance. Adult women present with symmetrical polyarthropathy, which usually involves hand, joint, and knee. Transient aplastic crisis. It can occur in infected patients with underlying hemolytic anemia, resulting in severe acute anemia. In this figure, we can see the fifth disease or rashes with slapped cheek appearance. Now, pure red cell aplasia, it can occur in those underlying immunosuppression due to persistent B19 infection, resulting in chronic anemia. Non-immune hydrops fetalis can occur in fetus, which results in fatal anemia and fetal death. Transplacental transmission occurs in 30% of the cases, and maximum risk is in the second trimester. Papular purpuric glove and sock syndrome, it presents as rapidly progressive, painful, pruritic, symmetric swelling and erythema of the distal hands and feet, usually in the spring and summer, which may be confused with acute meningococcemia. Now, laboratory diagnosis. Molecular methods. The most sensitive assay for diagnosis is PCR, which detects viral DNA example genes coding for VP1 and VP2 from serum, tissue, or respiratory secretions. Real-time PCR is used for quantification of viral load in the blood during acute infections. Antibody detection. ELISA has been available detecting antibodies against VP1 and VP2 antigens. IgM appears early, indicates recent infection, and remains elevated for 2 to 3 months. Antigen detection. Immunohistochemistry has been used to detect viral antigens in fetal tissues and bone marrow. Treatment for parvovirus infection. No antiviral drug is available. Symptomatic treatment is given. Immunoglobulins containing neutralizing antibodies to human parvovirus are available commercially. Now coming on to human papilloma virus infections. Human papilloma virus (HPV) is a DNA virus, belongs to Papillomaviridae family. It has a selective tropism for epithelium of skin and mucous membranes. It has more than 100 serotypes which produce an array of infections ranging from benign warts to malignant neoplasia of the cervix. Benign warts. They are small, hard, rough growth on the skin. There are following types: common skin warts, verruca vulgaris, and flat warts, verruca plana, are common in children, seen with serotypes 2, 4, 27, 57. Plantar warts, verruca plantaris, benign lesion widely prevalent among adolescents, seen with serotype 1. Anogenital warts, condyloma acuminatum, is a sexually transmitted infection seen among adults and is associated with HPV serotype 6 and 11. Now, pox virus infections. Morphology. Pox virus are the largest, 400 nm in length into 230 nm in diameter among all the viruses, large enough to be seen under light microscope. In this figure, we can see the plantar warts. Most complex virus, their structure does not fit into either icosahedral or helical symmetry, prick-shaped or ellipsoid. Envelope. Externally, there is an envelope made up of two lipoprotein membranes, outer and inner, with ridges arising from the outer membrane. The envelope encloses a core and two structures of unknown function called lateral bodies. Core or the nucleocapsid is biconcave dumbbell shaped. Possesses single linear dsDNA. It's the only DNA virus that replicates in the cytoplasm. The following are the pox virus of human importance. Variola was the causative agent of smallpox, the first disease to be eradicated from the world. Vaccinia was used as a vaccine for smallpox. Molluscum contagiosum virus causes warty lesions called as molluscum contagiosum. Smallpox. Smallpox was the first infectious disease to be eradicated from the world. It was characterized by highly contagious severe exanthema rashes. The agents of smallpox were variola major and variola minor. In this figure, we can see the smallpox virus schematic diagram, which has ridges, outer membrane, inner membrane, core, lateral bodies, double-stranded DNA, and viral enzymes. And smallpox virus electron micrograph is also shown. Smallpox timeline. Last natural case of variola major was seen in a Bangladeshi woman in Assam in May 1975. Last natural case of variola minor was seen in Malacca, Somalia, 26 October 1977. Eradication was declared by WHO nearly after 3 years of the last case, that is on 8 May 1980. Laboratory spread. There was a small outbreak in Birmingham 1978 due to accidental spread of virus from the virus laboratory, following which stocks from most laboratories have been destroyed. Maintenance. Currently, only 2 laboratories hold these stocks for smallpox virus: CDC Centers for Disease Control and Prevention, Atlanta, USA, and Center for Research on Virology and Biotechnology, Kolsova, Russia. Agent of bioterrorism. As vaccination was stopped following eradication, people born after 1980 are not immunized. Hence, smallpox virus can be a potential agent of bioterrorism. Reasons that made eradication successful. Variola was an exclusively human pathogen, no animal reservoir. Source: patients were the only source and there were no carriers. Case detection was easy due to characteristic appearance of the rashes. Subclinical cases were not transmitting the disease. Global smallpox eradication program was launched in 1967 by WHO with a strong intention international cooperation and intense effort. Disease was wiped out nearly after 10 years. Highly effective live vaccine, freeze dried from form was used, which has more stability, and multiple puncture technique was followed to administer the vaccine by using a bifurcated needle, which was found to be simple, effective, and economical. Clinical manifestation. The portal of entry of the virus was via the mucous membranes of the upper respiratory tract, aerosol transmission. Difference between smallpox and chickenpox. Incubation period of smallpox is 12 days, 7 to 17, while of chickenpox is 15 days, 10 to 21. Site of rash of smallpox is palm, sole, and extensor surface, while chickenpox involves axilla and flexor surfaces. Rashes are deep-seated and appear in single stage. Evolution is slow. Centrifugal distribution in smallpox, while in chickenpox, superficial and pleomorphic rashes which appear in crops. Evolution is rapid. Dewdrop rashes are there which have a centripetal distribution. In smallpox, fever subsides with the appearance of rash, while chickenpox fever rises with each crop of rash. After an incubation period of 12 days, 7 to 17 days, the patient develops the rashes. Description of the rashes. Smallpox rashes were unique in appearance and could easily be identified from the differentiated from the chickenpox. Rashes were deep-seated and all rashes in an area appeared in one stage. Evolution was slow. Centrifugal distribution, palm and sole and extensor surface were affected first. Fever subsided with appearance of rash. Laboratory diagnosis, direct detection in scrapings from rashes, intracytoplasmic inclusion bodies, Pasteurine bodies, electron microscopy, brick-shaped appearance with biconcave DNA core. Egg inoculation, characteristic pock formation is seen on the chorioallantoic membrane CAM of a chick embryo. Treatment of smallpox cases used to be treated with in past with vaccinia immunoglobulins and antiviral drugs like methiazone, pseudofovir, or tecovirimat. Vaccination. Live vaccine was highly effective. It was given as a single dose at 1 to 2 years of age. As an unattenuated live virus was used, diverse reactions were common, such as mild vaccinia-induced rashes. Cowpox vaccine, discovered by Edward Jenner, the father of vaccination, was in use before vaccinia vaccine was available. Variolation was the first attempt of providing artificial immunity against smallpox. It was used even before cowpox vaccine was available 17th to 18th century. Healthy people were inoculated with the skin scraping of a smallpox patient. In this figure, we can see the smallpox rashes over the face. Vaccinia. Vaccinia virus cross-reacts with variola and antibodies produced against vaccinia are protective for variola. This antigenic cross-reactivity was so much that vaccinia was able to eradicate variola globally. However, vaccinia differs from variola in many ways. It is non-pathogenic to humans, so produces milder skin lesions, produces an inclusion body called Guarneri body. Variola produces Pasteurine body. On CAM, vaccinia virus produces larger and hemorrhagic and necrotic pock lesions than variola. Molluscum contagiosum. Molluscum contagiosum virus is an obligate human pox virus that produces characteristic skin lesions. Clinical manifestations. Lesions. It produces dome-shaped pink pearly wart-like regions, 2 to 5 mm in size, umbilicated with a dimple in center. Lesions are found singly or in clusters anywhere on the body except on the palms and soles. Genital lesions are seen in adults. Transmission. Children are commonly affected, acquired infection by direct and indirect contact, example by barber, common use of towels, swimming pools. Rarely sexual transmission has been reported in young adults. Self-limiting. Lesions disappear in 3 to 4 months. There are no systemic complications. In HIV-infected patients, disease is more generalized, severe, and persistent. Lab diagnosis. Molluscum bodies are the intracytoplasmic eosinophilic inclusions seen in the skin scraping stained with histopathological stains. Electron microscopy and PCR can be used for confirmation, not cultivable. It cannot be propagated in tissue culture, embryonated egg, or in animals. Treatment of molluscum contagiosum. Surgical removal of the lesions by ablation, by cryotherapy or laser therapy is the mainstay of the treatment. Seroforward has shown to have some efficacy. As this virus does not cross-react with any other pox virus, smallpox vaccine is not protective. Other pox virus of human importance, they are zoonotic, mainly infect various animals. Human infection is rare. Example, monkeypox can produce vesicular rash similar to smallpox but milder. Infection can be prevented by smallpox vaccination. In this figure, we can see molluscum contagiosum lesions on skin, and in figure B, we can see the histopathological slide of skin showing molluscum bodies. Orf virus produce localized skin lesions called as contagious pustular dermatitis or mouth sore. Pseudo cowpox or paravaccinia can really infect milk handlers to produce nodular skin lesions called milker's nodule, while cowpox and buffalo pox can produce pox-like lesions and mild systemic illness. Now, after DNA viruses, we come to RNA viruses causing cutaneous infections. First of all is measles. Measles is an acute, highly contagious childhood disease characterized by fever and respiratory symptoms, followed by typical maculopapular rash. The causative agent measles virus is an RNA virus, belongs to Paramyxoviridae family. Pathogenesis. Transmission of measles transmitted via the respiratory route either by droplet inhalation over short distances, which is common, while small particle aerosols that remain suspended, especially in schools, hospitals, and enclosed public places in the air for a longer period, which is less common. Spread. The virus multiplies locally in the respiratory tract, then spreads to the regional lymph nodes, enter into the bloodstream through the infected monocytes. Primary viremia further multiplies in reticuloendothelial system, spills over to blood, secondary viremia, and then disseminates to various sites. Target sites. The virus is predominantly seeded in the epithelial surface of the body, including the skin, respiratory tract, and conjunctiva. Okay, now in this figure we can see the characteristics of measles virus: complex spot and buccal mucosa, measles or rashes on the face, and multinucleated giant cells of measles, infected cell lines. We can see. Clinical manifestation: incubation period is about 10 days, which may be shorter in infants and longer up to 3 weeks in adults. Disease can be divided into 3 stages. Prodromal stage. This stage lasts for 4 days, that is from 10 to 14 day of infection, and is characterized by manifestations such as fever is the first manifestation, occurs on day 1, that is on 10th day of infection. Complex spots are pathognomic of measles, appear after 2 days following fever, that is on 12th day of infection, and are characterized by white to bluish spot surrounded by an erythema. Appear first on buccal mucosa near second lower molar, rapidly spread to involve the entire buccal mucosa and then fade with onset of rash. Non-specific symptoms may be present such as cough, coryza, nasal discharge, redness of eye, diarrhea or vomiting. Eruptive stage: maculopapular dusky red rashes appear after 4 days of fever, that is on 14th day of infection. Rashes typically appear first behind the ear, then up spread to face, arm, trunk, and legs, then fade in the same order after 4 days of onset. Rashes are typically absent in HIV infected people. Fever on 10th day, then complex spot on 12th day, and rash on 14th day. Post-measles stage is characterized by weight loss and weakness. There may be failure to recover and gradual deterioration into chronic illness. Complication: children of less than 5 years, adults of more than 20 years, pregnant women, and immunocompromised hosts are at high risk of complication. Secondary bacterial infection: following measles, there is a profound immune suppression and fall of cell-mediated immunity, which in turn predisposes to various secondary bacterial infections. Otitis media and bronchopneumonia are the most common. Recurrence of fever or failure of fever to subside with rash. Worsening of the underlying tuberculosis with a false negative Mantox test. Complications due to measles virus itself: giant cell pneumonitis, Hatchett's pneumonia in immune compromised children and in HIV infected people. Acute tracheobronchitis, croup, diarrhea leads to malnutrition, including vitamin A deficiency. CNS complications. CNS complications are rare but more severe. Subacute sclerosing panencephalitis (SSPE) is the most common important CNS complication. The other include post-measles encephalomyelitis and measles inclusion body encephalitis. Lab diagnosis of measles specimen, nasopharyngeal swab, antigen detection by using anti-nucleoprotein antibodies, virus isolation by inoculation of specimen into monkey or human kidney cell line produces CPE as multinucleated giant cells, Warthin Fingley cells. Antibody detection in the serum against nucleoprotein antigen by ELISA and reverse transcription PCR detects viral RNA. Lab diagnosis specimen. Nasopharyngeal swab, conjunctival swab, blood respiratory secretions, and urine are the ideal specimen. Synthetic swabs are recommended. Antigen detection. Measles antigen in the infected cells can be detected directly by using anti-nucleoprotein antibodies detect immunofluorescence test. Virus isolation. Cell lines, monkey or human kidney cells are the optimal cell lines used for isolation of measles virus. Cytopathic effect may be observed after 7 to 10 days of inoculation into cell lines characterized by multinucleated giant cells, Warthin Fingley cells, containing both intranuclear and intracytoplasmic inclusion bodies. Shell vial culture is recommended for early detection within 2 to 3 days. Antibody detection. The detection of the measles specific IgM antibody in serum or oral fluid or fourfold rise of IgG antibody titer between acute and convalescent phase sera is taken as significant. Demonstration of raised titers of anti-measles antibody in the CSF is diagnostic of SSPE. ELISA is the most recommended test that uses recombinant measles nucleoprotein NP antigen. Reverse transcription PCR. RT-PCR is available targeting measles specific RNA such as NG nucleoprotein in clinical specimen. It is extremely sensitive and specific. It may also permit characterization of measles virus genotypes for molecular epidemiologic studies. RNA can be detected in specimen up to 10 to 14 days post rashes in contrast to virus isolation, which often becomes negative after 3 days of rash. Measles genotype. There are 8 clades of measles, which are further grouped into 23 recognized genotypes WHO. Genotype D8 followed by B3 and D4 are the common reported globally as well as from India. Treatment of measles. There is no specific antiviral therapy available for measles. Treatment is symptomatic and consists of general supportive measures. Vitamin A has been effective in reducing the morbidity and mortality due to measles. Prevention. General preventive measures, airborne precaution such as isolation in negative pressure room, use of PPEs such as N95 respirator, etc. must be followed while handling measles cases. Now, measles vaccine, live attenuated vaccine is available for measles strains. The following vaccine strains are used currently. Schwartz strain currently serve as the standard in much of the world. Adamonston, Zagreb strain and Moranten strain. Vaccine is prepared in chick embryo cell line. Reconstitution vaccine is available in lyophilized form and it has to be reconstituted with distilled water and then should be used within 4 hours. Vaccine is thermolabile, hence it must be stored at minus 20 degrees Celsius. One dose 0.5 ml containing more than 1000 infective viral units is administered subcutaneously. Combined vaccine, measles vaccine is available in combined form with rubella, MR vaccine, with mumps and rubella vaccine, MMR vaccine, and with varicella, MMRV vaccine. Indication. Under National Immunization Schedule of India, measles, rubella, MR vaccine is given at 9 completed months to 12 months along with vitamin A supplements and second dose of MR vaccine at 16 to 24 months. Contraindication for MMR vaccine are severe life-threatening allergic reaction to MMR vaccine, advanced immune deficiency state, example transplant, chemotherapy, advanced HIV, pregnancy, active tuberculosis, or has received another live vaccine within the past 30 days. Side effects include mild measles-like illness may develop in 15 to 20% of the vaccine. There is no spread of vaccine virus in the community. Toxic shock syndrome due to contamination of vial with Staph aureus toxins. Contact. Susceptible contacts over 9 to 12 months may be protected against measles if the measles vaccine is given within 3 days of exposure. That is because incubation period of the measles induced by the vaccine strain is about 7 days compared to 10 days for the naturally occurring measles. Measles immunoglobulin can also be given within 3 days at a WHO recommended dose of 0.25 mg per kg of body weight. However, both vaccine and IG should not be given together. At least 8 to 12 weeks of gap must be maintained. Epidemiology. Measles is an endemic throughout the world with epidemics which recur regularly after 2 to 3 years, typically in the late winter and early spring. Source. Cases are the only source of infection. Carriers are not known to occur. In apparent or subclinical infections are rare. Now, the reservoir human are the only reservoir of infection. There is no animal reservoir. Infective material virus is shed in the secretions of nose, throat, and respiratory tract of cases of measles, especially during the prodromal stage and early stage of rash. Period of communicability. Patients are infectious from 4 days before to 4 days after the onset of rash. Patients are highly contagious. Isolation is recommended from the onset of prodromal stage until the 3rd day of rash. Secondary attack rate is very high, more than 90%. Age. Measles is a childhood disease. Children 6 months to 3 years are the most susceptible group of developing countries. All children more than 5 years are commonly affected in developed countries or in vaccinated population. Immunity. No age is immune if there is no previous immunity. There is a single serotype, hence one attack, vaccine or infection gives lifelong immunity. Infants are protected up to 6 months due to pre-existing maternal antibodies. Epidemic of measles occurs if proportion of susceptible children exceeds 40%. Although disease burden has much decreased after the vaccine is made available, measles is still a leading cause of death in young children in many developing countries. World. The measles cases have dramatically reduced in recent days due to widespread vaccination. In 2018, there were 3,59,921 confirmed cases of measles worldwide with 1.4 lakh deaths compared to more than 40 lakh cases in 1980. Congo reported the maximum cases in 2018, followed by Ukraine and Pakistan. India, the burden of measles is substantially reduced due to widespread vaccination. In 2018, around 19,474 cases were reported from India compared to more than 1 lakh cases in 1980. Measles elimination. Measles is amendable to eradication. With the efficient and widespread immunization program, it is possible to eradicate measles from the world. WHO has introduced the strategic plan for achieving and maintaining measles and rubella elimination in WHO Southeast Asia region 2020-2024. The following objectives are set to achieve this target: more than 95% coverage with 2 doses of MR vaccine, develop and sustain a case-based surveillance system, develop and maintain an accredited measles and rubella laboratory network, strengthen support and linkages to achieve the above 3 strategic objectives. Measles is said to be eliminated if the confirmed cases are less than 1 per million population. The American region and some of the Western Pacific region, Australia, Hong Kong, Japan, Korea, New Zealand, Sri Lanka, etc., have recently achieved the measles elimination status. Now the next topic is rubella. Rubella vaccine produces a childhood exanthema similar to that of measles. Therefore, rubella is also known as German measles. However, unlike measles, it is highly teratogenic and can cause congenital rubella syndrome. Rubella belongs to Togaviridae family and is the only member under the genus Rubivirus. It contains ssRNA surrounded by capsid protein and an envelope. Its envelope contains a lipid layer from which 2 types of spike-like glycoproteins E1 and E2 are projected. There is only one serotype and humans are its only known reservoirs. Clinical forms. Rubella may present in 2 clinical forms: postnatal infection and congenital infection. Postnatal rubella. Postnatal rubella may occur during neonatal age, childhood and adult life. Transmission. Rubella virus spread from person to person by respiratory droplets via upper respiratory mucosa. Spread. Rubella virus replicates locally in the nasopharynx and then spreads to lymph nodes. Subsequently, viremia develops after 7 to 9 days and lasts until 14th day, by which time both antibody and rashes appear almost simultaneously, suggesting an immunologic basis for the appearance of rash. Clinical manifestations. Incubation period is about 14 days, range from 12 to 23 days. Subclinical infection may be seen in 20 to 50% of the cases. Rashes are often the first manifestation in children, but in older children and adults, 1 to 5 day prodrome often precedes the rash, which includes low-grade fever, malaise, and upper respiratory symptoms. Rashes are generalized and maculopapular in nature, start on the face, extend to the trunk and extremities, and disappear in 3 days. Lymphadenopathy, occipital and post-auricular is the most striking feature. Fortune spots may be seen in some cases. They are pinhead-sized petechiae, develop on the soft palate and uvula, usually start with the onset of rash. Complications. Arthralgia and arthritis are common in adults, particularly in women. Thrombocytopenia and encephalitis are rarely encountered. Lab diagnosis: isolation of virus, nasopharyngeal or throat swabs taken 6 days before and after the onset of rash. Now in this figure, we can see a child with rubella rash and cataract seen in the congenital rubella infection. Okay. Ideal cell lines, monkey or rabbit origin cells may be used. It can also be identified more rapidly in cell lines by shell-wild technique. Serology, antibody detection. ELISA is the preferred method of rubella diagnosis. It detects both IgM and IgG separately. Various antigens employed are whole virus isolate or recombinant E1 or E2 antigens. Results need to be confirmed by IgG avidity test to differentiate active infection from the past infection or vaccination. Molecular test RT-PCR is available for detecting rubella-specific RNA nucleoprotein N gene in clinical specimens. Congenital rubella syndrome. The most serious consequence of rubella virus infection is the congenital rubella syndrome. Rubella is highly teratogenic, affects ear, deafness, eyes, cataract, and heart, patent ductus arteriosus. The severity is maximum in the first trimester. Epidemiology source: the cases are the only source of infection. There is no carrier state. Duration of protection: once infected, the person acquires lifelong immunity. In India, still 40% females of reproductive age group are susceptible to rubella infection. Period of communicability of rubella is about 1 week before to 1 week after the appearance of rash. Transmission occurs via airborne, droplet, transplacental, and rarely via contact and sexual modes. Occurrence: rubella occurs worldwide throughout the year with a peak in the spring. Epidemics occur every 6 to 8 years with explosive pandemics every 20 to 25 years. The largest rubella epidemic postnatal occurred globally in 1962 to 65. However, with the increasing vaccine use, the epidemics are encountered less nowadays. World in 2018, 20,006 confirmed rubella cases were reported globally. Nigeria, followed by China, accounted for the maximum cases. In 2018, India reported 2,328 number of rubella cases. It was an outbreak of rubella reported from Rajasthan in 2014. Genotype: based on even protein coding region, rubella has been typed into 13 genotypes, 4 of which are commonly circulating in the world: 1E, 1G, 1J, and 2B. Genotype 2B is the predominant type in the world and also from India. Rubella is mild. For treatment, rubella is mild, self-limited illness, and no specific treatment is available. Prevention: general preventive measures. Airborne precaution must be followed while handling rubella cases. Rubella vaccine RA27/3 is a live attenuated vaccine for rubella prepared from human diploid fibroblast cell line. It is available singly or in combination with vaccines of mumps and measles. MMR vaccine. Scheduled single dose 0.5 ml of vaccine is administered subcutaneously. Following vaccination, seroconversion occurs in 90% of the recipients and immunity persists for 14 to 16 years or probably lifelong. Indication: in India, rubella vaccine is indicated for all women of reproductive age group, first priority group, followed by all children 1 to 14 years under national immunization schedule. Rubella vaccine is given along with measles MR vaccine at 9 to 12 months of age and second dose at 16 to 14 months in selected states. Precautions: vaccine is contraindicated in pregnancy as it is teratogenic. Pregnancy should be avoided at least for 4 weeks 28 days following a vaccination. However, if a woman conceives less than 4 weeks following vaccination, wait and watch policy should be followed. No immediate termination of pregnancy is required. Infants below 1 year should not be vaccinated due to the possible interference from persisting maternal antibody. Hand, foot and mouth disease, HFM disease. HFM disease usually affects children. It is characterized by ulcerations on oral and pharyngeal mucosa and vesicular rashes on the palms and soles, which heal without crusting. Fever and sore throat with flu-like symptoms are the other manifestations. In this figure, we can see the vesicular eruptions in hand, foot, mouth disease on hand, foot and mouth. Agents: HFM disease is mainly caused by Coxsackie viruses, rarely by other enteroviruses. Coxsackie virus A16 is the most common cause. Coxsackie virus A6 can cause HFMD with more severe manifestation. Enterovirus 71 also has been associated with cases in East and Southeast Asia. Transmission: the virus can spread to other through an infected person's nose and throat secretions such as saliva, sputum or nasal mucus, fluid from blisters or scabs, and also feces. Transmission occurs through the contact, direct or indirect, and droplets. Okay, so this completes our chapter. Now let's come on to the questions. A 7-year-old boy has developed multiple painful vesicles over lips and buccal mucosa. Parents revealed that 2 children of the school had similar presentation a few days back. Scrapings taken from the lesion of demonstrated presence multinucleated giant cell, Tasnac cell. Clearly, this is a case of herpes. Diagnosis agents and the lab diagnosis can be given. Now, a child presents with the vesicular rashes which appear first on the face and neck, face and trunk, rapidly spread to involve flexus surfaces, sparing distal part of the limbs. Rashes are bilateral and diffuse in distribution, appear with multiple crops. Fever appears with each crop of rashes. Clinical diagnosis, it's a case of chicken pox, and the prevention also we can write. A child presents with rashes starting behind the ear and then spread to the body. On examination, bluish white spots were seen in the buccal mucosa. What is the clinical diagnosis? Clearly, this is a case of measles. Okay, so now coming on to MCQs. All of the following are clinical manifestations of parvovirus B19 infection, except it produces Erythema infectiosum, yes. Transient aplastic rashes, yes. Condyloma acuminata, no, it does not produce Condyloma acuminata. And hydrospitalis also is produced. The correct sequence of manifestations seen in measles is it is fever, Koplik spot, and rash. Subacute sclerosing panencephalitis (SSPE) is a complication following which viral infection? It is measles. Which virus vaccine strain combination is not correct? It is rubella Schwartz strain. This is wrong. Following rubella vaccination, pregnancy should be avoided for at least how many months? It should be avoided for at least 1 month. Okay. So this completes our chapter. Next, we'll be starting with the parasite infections. Okay, like, share, subscribe. Thanks for watching.